my bone building friends. I'm excited to share another recent interview with you. This one is with Dr. Doug Lucas, who's an orthopedic surgeon who focuses his medical practice on helping people prevent fractures. Awesome, right? I know. He did his orthopedic surgical training at Stanford University, and he's part of the American Academy of Anti-Aging Medicine, the Academy of Preventative and Innovative Medicine, and Wild Health. He's also the founder of Optimal Bone Health and Optimal Human Health. He's passionate about working with patients who are looking to optimize their health through a customized approach that's based on genetic and extensive data and lifestyle evaluations. He also has a YouTube channel that you'll probably like if you like my content. So when you're done with this interview, go ahead and check out his channel if you haven't already. On that note, I'll share the recent interview that I had with him. I hope that you find this information helpful. And if you have questions, please reach out and ask. Hello, everyone. Welcome. I am so excited. I have Dr. Doug Lucas with me here today, and I would like to take a moment and introduce him. Dr. Lucas is the founder of Optimal Bone Health and Optimal Human Health. He is a Stanford University trained orthopedic surgeon. He is a member of the American Academy of Anti-Aging Medicine and the Academy of Preventative and Innovative Medicine and Wild Health. He's board certified in orthopedic surgery, board certified in anti-aging and regenerative medicine. He's a fellow in anti-aging and metabolic medicine, and his passion is to work with patients looking to optimize their health through a customized approach based on genetic data, extensive evaluation, and in-depth lifestyle examination. So thank you. That's a really impressive list.
Wow, thanks. It sounds like that when you read it off. Thanks for doing that.
It's good to hear now and again.
Mm-hmm.
It really is. I appreciate you coming to speak to our group. Give me a hi if you're here and joining live, and we'll start to see those coming down.
Starting to trickle in.
Yes. Starting to trickle in. Can see you joining. So excited. And then looking at, we have some pre-submitted questions. And then also later on, we will also open this up so that if you're live here with us in the group, there will be some time for answering questions a little bit later on. I'd like to start out. I think it's a really special and remarkable thing as a physician to dedicate your career to helping other people on the preventative side. And I would love to have you share what inspired you to dedicate your career and life's work to helping people in this space. How did this come to be?
Gosh, the way that I got here, I don't know, is pretty unique. There are some really interesting people in the sort of the longevity space, the health span space. We talk about what those definitions mean. But when I started my practice, as you mentioned, Stanford trained, I was training in orthopedic surgery. So I'm an orthopedic surgeon by training, went into a traditional medical model. I practiced, I operated, I did all those things. About a year, 2 years in, I recognized that I really felt like I was just chasing my tail with my patients because we were doing great stuff with surgery, but I wasn't having the impact that I thought that I would. And I kind of had two different scopes. I had the trauma side where, we were fixing fractures that a lot of people think of with orthopedics, but then I had the elective side. And the trauma side was very clear, but the elective side was very much people coming in with pain, people coming in with swelling, people coming in with subtle arthritis, people coming in with diabetes, with ulcers. And that stuff started for them decades ago. And it started with deficits in nutrition, lifestyle, exercise, stress. I mean, all the foundational things. And so by the time they got to me, they wanted a quick solution. They wanted the surgery that would fix them. And I had to tell people, I don't have a surgery for this, even though I have an x-ray that shows a thing and I could put metal in there and I can make you different, but it's not going to make you better. And so at the same time, my wife started a company called PhD Weight Loss and Nutrition, and she really focused on reversing metabolic disease and helping people with diabetes. And I started seeing this impact of this lifestyle change And it just blew my mind that the things that she was able to do purely by helping people to eat differently would prevent them from needing my services in a couple of years. And so it kind of clicked for me that maybe there is a different path. And I was really excited about teaching my patients about nutrition, and sort of went down this very long, arduous path of getting out of the traditional medical model and all the training I needed to end up where I am today. But it was really that shift, that notice that, gosh, I feel like I'm not really providing the incredible change that I thought I could, even with all of the cool technology that we have in the field of orthopedics. And I found that for me, I love educating people. I love getting data and showing people how they can improve their lives, improve their lifestyle, make little simple changes that have tremendous impact. So that's why we ended up creating what we created.
That's a beautiful thing. It really is. What would you tell someone who's just been diagnosed with osteoporosis?
Stop freaking out. Yeah. I really struggle with the diagnosis of osteoporosis. And I talk very openly about this. And my goal is never to disparage the traditional medical doctor or the doctors in the field. But we have to understand as consumers of healthcare that the system is set up in a very specific way. And you could maybe say it's set up to make money, or that it's for the pharmaceutical companies or the hospitals or the government or whatever. But take all of that aside and just identify that the system as designed is really good at diagnosing acute problems and fixing those problems. If you're in a car accident and you need surgery to fix a broken bone or a lacerated liver, or you have a heart attack, like, our system is amazing, second to none. But if you have a problem that took 20, 30, 40 years to develop and is going to take a comprehensive approach to fix, our system sucks at that. It's just outright terrible. And that's true with osteoporosis. It's true with diabetes, dementia, cancer prevention, like all of that stuff, because it's not a quick fix. There's not a drug for that. And we could talk about drugs for osteoporosis, but there's not a good drug for that. And it's because it requires a big picture thing. So when you get a diagnosis, you say, oh, my T-score is negative 2.6. I have to, wear a padded suit and not go do anything. Like, no, there's so much more that you need to know. But sadly, your primary care doctor, endocrinologist, rheumatologist, whomever, isn't going to get that information for you. And that's where we see people that are, following you, they're following me. They are searching for information, because you need more information before you decide how much to freak out. There are times when you should be concerned about fracture risk, and that's really what it's all about. But there are a lot of times, and a lot of my patients that come to me with this just fear gripped around their diagnosis. And the first thing we do is recognize, look, it's not that bad, right? Your risk of fracture is actually not very high. Let's be smart, but all we have to do is just recognize that, figure out where we are, and then make a plan forward. And so you don't necessarily need to be freaking out about it.
Yes. That's such an amazing thought. Don't freak out about it. I think that's a really common feeling for many people. Absolutely. To feel like they don't know what to do.
Yeah, absolutely.
So don't freak out. It can be okay.
Yeah.
So I think this is a really interesting question, given your background, to ask. But what do you find most fascinating about our bones and about bone health?
Man, well, gosh. So one of the reasons why I went into orthopedics is because bones are amazing. I think a lot of people will think of bones as like a mineral repository, or it's like the structure of our body. And yeah, those things are true, but bones are also very dynamic. And I forget what the actual statistic is, but we are always turning over our skeleton. Our bones, a decade from now, will be completely different than they are now. They are a live thing. They make blood cells. They make parts of your immune system, right? They're doing so many things. And we really take that for granted when we think about how we treat bones. And this really feeds into the conversation on drugs, because if you just squash bone metabolism, you're squashing a lot of stuff, and if you're messing with osteoclasts and osteoblasts further up in the cell lineage, you're messing with things like the immune system. So, so we have to really consider what they are. The fact that they have the ability to heal is very remarkable. And I always kind of laughed when people would look at what I did as a surgeon and say, "Oh my gosh, you fixed my thing." And I would, my thought is, I didn't fix anything. I just lined it up. The body will do it all, right? Like all I have to do is just get it in the right zip code, and it'll do its thing. And so we get way too much credit when it comes to healing things because the body does it, and the bones are very remarkable in that way.
That's really something to think about. I think that's an interesting place to perhaps segue into a discussion about medication. Do you think that medication has a place in treatment for osteoporosis?
It absolutely has a place, but I find most patients that come to me, this is the typical story is they have, they recently went through menopause. This is my classic patient. Recently went through menopause, got screened for whatever reason, because that's technically too early, right? But they got a DEXA for whatever reason, diagnosed with osteoporosis. It was a complete surprise. They're freaking out. They come to me and their doctor wants to put them off Fosamax, right? Like this is sort of like the circle that we see. And I think that's very inappropriate from a provider perspective. And I'm happy to say that openly, knowing this will be recorded and could be distributed to the medical board. Because while they might meet the criteria according to the World Health Organization and FRAX and all these other things, for medication, the provider doesn't know yet two main things. Why are they losing bone? Which is it's a big thing, right? We can talk about that. But they also don't know, are they rapidly losing bone, or do they have an issue with making bone? And so to throw a drug at somebody without knowing those two things is really putting on a blindfold and throwing darts. Now, to be fair, a doctor in the traditional medical model only has a couple of tools. So it's kind of like you pick A, B, or C. But I see the bisphosphonates used like that all the time because they're oral, they're easy, and they're cheap. And so people will get placed on a bisphosphonate. But the bisphosphonates are drugs that will poison bone. They completely squash bone metabolism. And unless you're rapidly losing bone, it's not the right drug. So I see that error all the time. And I have a lot of patients that have been on bisphosphonates for years, and they look at me and they're like, my bone just keeps getting worse, and it's like, well, it's because it's not the right thing. You're on the wrong drug if you're going to be on a drug. And a lot of times they don't need to be on a drug. So I think there is a role, and there are a lot of scenarios where bone loss happens rapidly. Before we started, we were talking about steroids. So steroids is a case where, hey, maybe you do want to slow down that bone loss. If you're on estrogen inhibitors because you have breast cancer, you're on chemotherapy, like there are medical scenarios where you're going to rapidly lose bone, and a bisphosphonate could be the difference between, having a bad problem and you have a good solution for, hopefully, or a bad problem leading to another bad problem. So there is definitely a role for the drugs. I think that they're overutilized, and I think that the reason why people need drugs is underappreciated. But that takes a much bigger approach and a bigger viewpoint to be able to make those recommendations.
Yes. I heard you mention FRAX. Could you speak to what FRAX is and how it's useful and what the limitations of FRAX are?
Yeah, so FRAX is something that, if you actually did a YouTube video on this recently, if you go to a doctor and they look at your T-score and they ask you some questions, and then they say, you have a 20% chance of having a fracture in the next 10 years, you're like, whoa, how'd you know that? Like, wow, yeah, it's amazing. So they probably use this tool called FRAX. So FRAX is an online available free calculator. Anybody can go there and use it. And if you just Google FRAX, you'll find it. And it is based off of a very large study looking at fracture risk and not all, but several risk factors that go into whether or not you will potentially suffer a fracture from poor bone health. And it's pretty good. So it is a tool. We use it. We have in our bone reports, we have what do we call it? Our scorecard. So we have a scorecard. It's in the front of our report, and we calculate a whole bunch of stuff, and we have FRAX in there too. We have DEXA in there too, and I can talk about why DEXA is good or bad. But we use FRAX because it does give us a sense of how high of risk you have of fracture, because it incorporates things like your genetic history. Do you have a family history of fracture? Have you had a fracture? Do you smoke? Do you take steroids? A bunch of different risk factors. It includes, when you go to the website, you'll have to pick geographic location, and you'll have to also pick ethnic background. And so it can separate out some of those things because there are big differences there. And then you can put in a T-score, but you don't have to. It'll give you a number without a T-score. And then it'll tell you your risk of fracture over the next 10 years for your hip and risk of fracture over the next 10 years for major osteoporotic fracture. And based off of those numbers, then your doctor will say, hey, you meet criteria for pharmaceutical management. So it's helpful. And so it's good because you don't have to know anything about anything, and you can sort of treat a patient for osteoporosis in the traditional medical model. So there's value there. Where it falls short is that there are a number of variables that are not listed in there. And so the one that they most get dinged on is that I don't think there's anything in there about falls. So I don't think it talks about falls at all. Obviously, if you're falling, you're at much higher risk of fracture. Other areas, I think, where it probably falls short is that it really doesn't take into account sort of like, why you have osteoporosis. It doesn't take into account, are you rapidly losing bone, delta of T-score from one time to another. So, if I put my numbers into fracs, like my risk of hip fracture is low, but it's not zero. And I'm thinking, like, really? Like, I'm pretty sure my risk of hip fracture is probably zero over the next 10 years, from a major osteoporotic fracture perspective. So, it's not perfect, but it is reasonable. And I think if you're somebody who's out there and you're searching for information and you're wondering, shoot, like, what is my risk? You can go look it up, and you can get a sense. I think that more importantly, more than just that one point in time, what's more important is that you look at the delta over time. Are you getting better? Are you getting worse? And that's something that I talk to a lot of, certainly my audience and my patients about. And we're clearly measuring these things. But for people that aren't, make sure that you're not just sticking your head in the sand and you're actually repeating these things over time, because it's free, it's available. It's awesome.
Yes. I love that, going back and repeating it and looking at it again, trying to check and evaluate again and again. How is this going? Are we going the right way? Or are we going the wrong way? What do we need to shift and change to make it all happen? And then looking at DEXAs, what are the positive things about DEXA and what are the limitations? What do you see there with DEXA?
I have a kind of a love-hate relationship with DEXA. I don't like that the diagnosis of osteoporosis is tied to DEXA. So it makes it feel like osteoporosis equals DEXA. And the truth is that osteoporosis is a much bigger thing. Osteoporosis is an imbalance of bone metabolism. DEXA is just simply how we measure bone density. And they are related, but not always related. And so, the nice thing about DEXA is that it is pretty much globally available. So we have a benchmark that we can talk about. It doesn't matter where people are. We have, because of our YouTube channel, we have a kind of significant international following. And it doesn't matter if I have a patient in Italy or Australia or Canada, they all have a T-score, Yes. So that's helpful. But the weakness is that it, again, only tells you about your bone density. It doesn't tell you anything about bone quality outside of density. So we don't know about strength, and strength is a combination of both density and bone quality. And so we know that there are people that have very low bone density that have pretty good bone quality that are probably not at high risk of fracture. I can't guarantee that. But when somebody's deciding, hey, should I be on a drug? And we have that information, it's certainly a much more challenging question, right? But we also know that you can have better improved bone density over time and still suffer fractures. Or you can have very dense bones that are actually pretty fragile because it's more like chalk. Right? If you have very dense bones and you don't have the right collagen, the right protein, the right soft stuff in between holding it together, those bones actually break easier. So we are more than our bone density. I just finished a draft for a book on osteoporosis, which I'm super excited to get out. And so I talk about this in the book, and there's really three areas that just popped up into my research when I was looking at DEXA. And what's interesting about bone density is that if you look at some drug classes, so raloxifene, for example, which is an estrogen response modifier, so it's kind of like estrogen. It will reduce fracture risk, but it doesn't really improve DEXA very much. So BMD doesn't really go up very much, but fracture risk improved quite a bit. And so the researchers, it's kind of funny in the conclusion, they're like, well, only about 4% of the fracture risk we can explain by DEXA. The other 96% is unknown. And it's like, well, it's the other stuff, like it's the strength, right? Another interesting point on BMD was when I was looking at PPIs, proton pump inhibitors, so a drug you take for acid reflux. And it's really confusing if PPIs cause osteoporosis or can contribute to developing osteoporosis. And the reason why it's confusing is if you look at the literature, taking PPIs doesn't change BMD. So bone mineral density doesn't change in people that are taking PPIs, but fracture risk does. And so it's just really compelling to say, like, look, it's more than your bone mineral density. It doesn't always correlate. And so there are multiple examples. I could keep going. So DEXA has a weakness there where we are more than our BMD. But then also there's variation in DEXA. So when something is considered the gold standard, we now have to assume that the gold standard is right all the time. And we know that DEXA is not right all the time. There's variation from operator to operator. So if you have somebody comes in and does a scan on you, and then that person goes to lunch and somebody else comes in and scans you again for some reason, you would likely get a different score. If you go from one machine to the next machine, you're going to get a different score. Now, it's not hugely different, but it can be significant if you're looking for, a 10% change in T-score, which is not a big change. I've seen that from machine to machine. So it's interesting, and then we look at other imaging modalities and you say like the REMS, the ultrasound that's not very available. Is that more accurate or less accurate? Well, you'll never know, because if something's considered the gold standard, if the other thing is different, you don't know which one's right. And we have no other tool to use. So again, love-hate relationship. Glad that we have it. I just wish we had something different.
Yes. Something a little more comprehensive.
Yeah. I want to know about strength.
Yes.
I ultimately want to know, how hard do I have to work to prevent this patient from having a fracture?
Because the fracture risk is the really significant part rather than density.
Right. I'm not really interested in bone mineral density. I'm interested in fracture risk. And BMD doesn't tell us everything we need to know.
No. You mentioned something in there about protein. And I would love to ask you about what you consider the best sources of proteins.
This is a very weighted question.
It is. I've had long discussions. People have sent me long emails asking about this just in the last week, asking about different protein sources and how to get them.
So I don't pull punches on this topic. And if you watch my YouTube videos, you'll know that. So I think that the best sources of protein are by far going to come from animal sources. And this is challenging in the osteoporosis community because so many people eat a vegetarian or vegan diet, a lot of times based on the principles around pH in diet and alkalizing to avoid demineralizing your bone. I'll put that on the shelf for a second. But if you go back to the protein thing, we're animals. And the amino acid composition of protein that comes from animals more closely mirrors the essential amino acids and in the quantities that we need them. So gram for gram, you're going to get a better protein from animal products than you are from plants. Not to say that you can't manipulate that and you can get a complete protein from plants. You can. If you do it to match animal protein, it's going to be highly processed. It has to be by default. And if you don't, and you're just mixing and matching vegetables, you are eating a lot of vegetables, for one. And two, you're getting a lot of the other nutrients with them, which could be good depending on the source, but it could also be bad. I find a really interesting combination is people that are eating a plant-based diet and are also struggling with weight, which is it's in the osteoporosis community, not as high as in other areas. But I really struggle with limiting carbohydrates in people eating a plant-based diet and also trying to get enough protein, because protein from plants comes with carbohydrates almost universally, except for soy. And so in my opinion, animal products is the way to get protein. And we are recommending our patients are eating quite a bit of protein. So we're a gram per pound of desired body weight, unless they have kidney issues. And for people that have some gut dysfunction and they're having issues absorbing, they might even need more. So we have people that are eating up to 1.5 grams per pound of desired body weight. And so I'm almost 200 pounds. So that for me is 200 to 300 grams of protein a day. That's really hard to get from a plant-based diet.
It is. And are you spreading it out throughout the day?
Mm-hmm. Yeah. So the company has origins in the health span space. So you mentioned the two companies. We have Optimal Human Health, and then we have Optimal Bone Health.
Yes.
And so it's the same team. It's just a different different avenue, different resources. That's why we split them out. And we used to talk a lot about fasting on the Optimal Human Health side, for people doing it for longevity, for diabetes remission, et cetera. I see people on the osteoporosis side doing the same thing, where they are kind of they're listening to whatever influencer, listening about the concepts of fasting. And it does sound great. It is great for the right person, but it is darn near impossible to get adequate protein and fast on a regular basis if you're doing any meaningful fasting window. So if you're getting to 16-8 feeding window, it's really tough to get enough protein in. So my osteoporosis patients are probably eating 3 to 4 meals a day, or 3 meals and a snack. And even then it's tough to get enough protein in.
Yes. Yes. I have another protein question. It's a collagen question. It's the Fortibone question specifically.
Yes. I don't think it's live yet. I just recorded on this topic because I get this question so often. So I spent a lot of time on the Fortibone website, and I was very confused by their claims. So they talk about, and I could actually pull it up and look at it to be accurate, but basically they talk about this, significant change in BMD with Fortibone specifically. And I thought, well, that's cool. And then they have citations on their site. And I looked up those studies, and none of those studies had anything to do with what they were talking about. So I think that's now that I've looked into it more, there is actually a study, and I think they just screwed up their website, which I guess we all do that sometimes. But the study that they're referring to is a study that they paid for. So there's some bias there. Now, the study itself was actually reasonably well designed, and it did show an increase in bone mineral density. The challenge that I have is that statistically it was significant, but clinically not amazing. And then I look at this and I say, well, right, so if I were a researcher and I wanted to research collagen, which is a globally available thing, why would I then select this one special formulation from this one company out of Germany to do this study on, right? It just seems very it's frustrating for me. Now, I understand they pay for the study, so okay. So I feel like there's a lot of bias in this study, and I certainly question the results. And to say that this is a clinically significant difference, I don't think is true. I forget what the actual numbers are. They're in my video. It's not a big difference. I'll put it that way. So I think it's probably not bad, but it's expensive to come from there. And so the question then for my patients is, okay, do we want to use collagen? If so, do we want to use I would say a US-based collagen peptide, and then assume that it's going to do something for the bones? Or do we want to use, this commercial product that has research behind it that potentially has significant bias that's way more expensive? And honestly, my answer is it probably doesn't make our list most of the time anyway. In fact, actually, I can tell you that it never makes our list. So we don't actively put people on collagen. Now, that said, a lot of our patients take collagen because it's, it does work for skin, hair, and nails, and it's a source of protein even if it's incomplete. So it's not bad, but is Fortibone the answer to osteoporosis? I don't think so, not independently. It's probably not going to hurt you, but I don't know that it's worth the cost.
Straight up amino acids.
Right. You kind of come down to it, right? Aren't they just amino acids? Mm-hmm. And this is the other thing too, is if they're getting adequate protein from good sources, why do they need collagen?
Yes.
Now you could maybe argue, hey, but I eat a plant-based diet and I wanted to get some collagen, or I guess maybe you can't do that. I don't know. So anyway, there are places where maybe it makes sense, but I think for us, it never actually fits into our list of top 10 or any number of supplements.
Because you're seeing things that are better.
Oh yeah, there's just, I mean, in our approach, we're looking from the bottom up. So we're talking about nutritional deficiencies. So we're spending a lot of time, we're fixing the gut, we're fixing nutritional deficiencies like B12 and D, all the other things we can measure, and magnesium. So when we start building out a list, we get to a lot of stuff really fast before we even get to like the advanced stuff. And so we are always working to prevent our recommendations from being overwhelming, because if I just rip through labs and I just check all the boxes, I mean, the list of stuff would be massive, and it doesn't include collagen. And so, yeah, there are so many tools, and this is why I'm so active on creating the YouTube videos, because there are so many tools to improve bone health that if you're worried about taking a drug, you have so many things you can do. This is it's almost silly how worried people get about osteoporosis, but I get it. I'm not saying they shouldn't be, but there are so many things that they can leverage. And so that's where, yeah, so collagen for me, it doesn't make the list because there are so many things.
I have some follow-up questions that are coming into the Facebook group right now. I'm going to go ahead and ask them because they're just pertinent. Okay. Someone's asking the question, for meat-based protein, must you eat red meat?
No, I would say if you go back to like the health span side, if you're looking for the most dense and most compatible protein source, it comes from red meat. And the reason why I like red meat is that if you think about, what a cow or the other, animal is similar. If you think about what their digestive system does, they essentially eat vegetable waste that nothing else can eat, and then they turn it into high quality protein. It's really remarkable. Because they have more than one stomach, they are processing out all the stuff that is coming in through the vegetables that they're eating. So they're essentially purifying the product as it comes. So then you get on the other side and you have this a really dense protein source that has iron, that has creatine, it has a lot of B12. Like it is unparalleled from a protein source perspective. Other sources of protein are good. So chicken, pork, for example, the white meats. The white meats are good from an amino acid profile perspective. The challenge that I have with them is that they only have one stomach. So what they eat, you eat. So if you have chicken that is out there feeding, and they're chowing down on corn and soy. So if they're chowing down on GMO corn and soy with pesticides on it, you're going to get some of that. Same thing with pork, and so it's really hard to know. They say it's pastured pork. I'm like, well, what'd they eat? You don't know. Now I have a dozen chickens outside my window, so I know what they're eating. I don't raise pigs, but I eat a lot of eggs, and I don't eat my chickens. So, but I do eat a lot of red meat. Now there are some challenges with red meat when it comes to saturated fat, and this is where the big picture is helpful, because for us, we are, when patients will allow us to, we're getting a genetic profile. We're looking at saturated fat risk factors. So we could potentially restrict red meat based off of that. But short of the saturated fat component, I don't think there's a better protein source.
Interesting. There are a couple of follow-on questions. Someone is asking, what are the best sources of proteins for vegetarians and vegans? And someone else is asking about whey protein powder. We're really in the weeds of protein.
Yeah, no, it's good. It's such an important topic, and it's one that a lot of people will talk about carbohydrates and fat all day long, but nobody likes to talk about protein because you have to talk about animals, and so it gets uncomfortable. But so I'll answer those backwards. So whey protein is a great protein source if you tolerate it, and the unfortunate thing is it's hard to know sometimes if you tolerate it. So we do a fair amount of functional testing. We don't do it on everybody, but we'll do functional testing on dairy tolerance, and we'll know if you tolerate whey. I personally don't tolerate whey protein. And I can feel it. I don't feel good when I consume whey protein. So I use a hydrolyzed beef product, and there are a couple of different companies that make that, and it tastes great. It doesn't taste like beef. So whey is plus or minus, and functional testing can help differentiate that. It's a great protein source if you can tolerate it. And then best protein source for plant-based individuals, you run into the issue with soy around here. And so soy, again, is a plus minus. So I think soy, because it doesn't come with all the carbohydrate load, is a complete protein. So it is one of those rare, like it's a plant-based complete protein, that's the only one, I think. And I'm not an expert in this space, just for the record. But soy, then you have the questions of the phytoestrogens, and is this better for bones? And I think the research says probably. Then there's the challenge of, well, is it clean? Did it, does it, what about the anti-nutrients? And is it GMO? Is it organic? Like, what's the source? Because really, if you're going to eat a fully plant-based diet and get 150 grams of protein a day, like, you're going to eat some soy, or you're going to eat a lot of, because that's the other, beans and nuts are the other sources. And people will talk about, like tempeh and other processed things. I would stick with, if you're going to do that, stick with the things that have very few ingredients. Stay away from the synthetic meats. They're just garbage, absolute garbage. So if you're going to go that route, stick with the true root of being vegan and vegetarian, which is to eat a whole food plant-based diet. But then you got to really do the math. It can be done, and it can be done well. It's just really hard. And so for the patients that come to me that are eating a plant-based diet, typically they have fallen down the rabbit hole of processed food because it's easy and it's abundantly available and they've made it cheap, but they feel terrible. And so we have that hard conversation and say, look, like, what are your goals? What are you willing to do? Are you willing to add anything in? Do you want to stay this way? Because we can work with anybody. But finding that, especially like men, so let's take a 160-pound man, trying to push 180 grams of protein through a plant-based diet is really tough, especially if they have metabolic dysfunction. So we can always try, but it makes it harder.
Yes. I really appreciate you taking the time to speak to that point. Thank you. Could you explain the 4K method and how it's useful for patients?
Yeah, I hope you mean the 4R method, because I don't know the 4K method, but
yes.
Yeah,
I
okay.
do. It's a typo on my part.
R's and K's look alike. But if there's a 4K method, I want to know about it.
It's yours. It's an R.
It's an R method. Okay. So we're always trying to find ways to explain what we do. And on the health optimization side, we call it a health optimization pyramid, and it has to do with the layers of treatment, starting with lifestyle and then supplements, and then hormone optimization, and then peptides, and then at the top, pharmaceuticals, right? So you have this like layered approach. With bone health, that doesn't really, it's the same thing, but it doesn't really make as much sense, because from a health span perspective, we're not really looking at why. Like, why are you in the condition that you're in? Because a lot of people in that situation are not in necessarily a condition at all, right? They just want to live better longer. With bone health, we really have to get to that first thing, that first R, which is to recognize why you're losing bone. I want to know why you're losing bone. When you read about osteoporosis, you'll read like age-related osteoporosis, right? Like as if it's normal. And I already talked about this earlier, like it doesn't need to be normal. Now, you could say, every woman will go through menopause if she lives long enough. And if you go through menopause, you will lose bone. That's true. But loss of estrogen in menopause is not the reason why everybody has osteoporosis, right? We find a tremendous amount of gut dysfunction in osteoporosis patients. We find a lot of historical, drug use, PPI use, and by drug, I mean pharmaceutical drugs. It could be alcohol abuse, could be other stuff, but you have to like go back and figure this out. And like, why are you losing bone? Did you have poor bone quality to start with? Do you have a genetic predisposition to have osteoporosis? Because without that information, you can't go to the next R. And the next R is to resolve or reverse those causes of bone loss. Sorry, it's reversed, not resolve. But either way, reverse those causes of bone loss. And the goal there is to formulate this plan, which then is the health optimization pyramid, but formulate this plan that starts with lifestyle and nail all of those foundational things. So just to be complete, so that's nutrition, exercise or movement, sleep, and then the fourth pillar, I call it spiritual health sometimes I call it mind, body, spirit. I'm all over the place with that one. But understanding your why about your life really in general. This gets a little woo-woo comprehensive. But if you don't have those things, then there's no amount of supplement, estrogen, whatever I can give you that's going to make you better. Once you have that nailed down, then the next step is supplementation, and preferably targeted based off of metrics. And then hormone optimization or replacement. In this population, a lot of times it's replacement, but that's a risk-benefit conversation to have. And then above that is peptides, and we can talk about what that means. And then at the very top is pharmaceuticals. Do you need pharmaceuticals? And we do recommend them occasionally. I would say out of the, I don't know how many 100 patients we have, I can think of 3 times that I've recommended a drug. So it happens, but not often. So that's the first 2 R's. Sorry, the third R then is to retest. So whatever testing we did, we got to retest to make sure we're heading in the right direction. And then the fourth R is to revive your life and live without the fear of fracture, because that fear sucks. I see it a lot.
It does. I think the fear of fracture is a really serious thing.
Yeah.
Makes a difference.
It's really debilitating, and it's really unfortunate.
It is. And then, of course, I loved having you take a moment to talk about the spiritual element, because it's going to affect in a very real way the stress that we experience in our physical bodies, which then, of course, has its own effects on bone health. So looking at that component, even if it seems a little woo-woo, is an important thing, because it has to do with our overall well-being.
Absolutely.
That's a beautiful thing. The next thing that I'd like to ask you is about how hormones affect bone health.
Yeah, I kind of led into that, didn't I?
Did.
So I spend a lot of time in my book talking about hormones, because our population is a lot of people that are around kind of perimenopause, early menopause, right? These are patients they've been diagnosed as a surprise, and they are generally really aggressive about doing something about it, which is awesome. I love it. We have another subset of population that is sort of in that like 60 to 70 age range. That age group underwent such a disservice in the early 2000s when the Women's Health Initiative and other studies came out. So prior to the early 2000s, hormones were being used in different ways for a lot of different things. Now, some of them were actually not particularly appropriate, probably. And there was probably some misuse of hormones in sort of the health span, longevity, anti-aging space. But when those studies came out and the interpretation of the early results were spread through media channels at the time, hormone replacement basically stopped. And doctors were taught, and I was even taught still, and I was did I go to medical school? 2005. So shortly thereafter, I was taught estrogen, breast cancer, right? Like that was it. Estrogen, breast cancer, testosterone, prostate cancer, testosterone, heart attack. We never talked about progesterone. And so essentially millions of women overnight got ripped off of their hormones. And the subsequent decades, it has been a struggle to help people to understand the risk-benefit equation. What's frustrating about going back and looking at that retrospectively is when you look at the data that was presented, what they said was true. So it wasn't erroneous. But if you really look at the data, and this is really hard to do as a non-professional, you should really almost take the opposite perspective. And so I'll just speak to that for a minute. So the Women's Health Initiative, if your listeners don't know what that is, so massive study, I forget how many participants, but let's just call it a massive, well-funded study and well-designed study. They had an arm of patients that were on a form of estrogen and a form of progesterone, and I'll speak to that. And then they had an estrogen only arm. 5 years in to the study, they stopped it early because of the risk of invasive breast cancer and the risk, not quite significant yet, but headed in that direction, risk of blood clot and stroke. And so they stopped that arm, the progesterone and estrogen arm, early because of the overall risk of death. But the estrogen only arm, they let keep going. So if you look at what they used an oral estrogen, Preventative. So it's a estrogen that comes from horses and has different forms of estrogen and at different levels than we as humans do naturally. So that's an oral estrogen, and that's an important point. And then they used medroxyprogesterone acetate, MPA, which is Provera. So Provera and Preventative together, which it was sort of like it was the two that the pharmaceutical companies developed the most of and pushed the most. So you had those two, and it made sense to study those because they were the most two commonly used. But we know now that MPA, that synthetic progesterone, which is known as a progestin, by itself actually has an increased risk of invasive breast cancer and blood clot. So we know that. We also know that oral estrogen, if you compare it to other forms of estrogen, has an increased risk of blood clot. So go back to the Women's Health Initiative. You had a progesterone and estrogen arm using an oral estrogen and a progestin compared to the oral estrogen only. Now, still an oral estrogen, but an oral estrogen only. And then they stopped the combined group because of the increased risk of invasive breast cancer and blood clot. So was it the estrogen? No, because the estrogen group continued on. And in fact, when they concluded that, I forget how many years later, it actually showed a subtle but clinically significant and statistically significant reduction in invasive breast cancer. So, okay, so now I'm told as a medical student, estrogen equals breast cancer, but actually the estrogen arm of the Women's Health Initiative showed protection from breast cancer. So super frustrating. So now I have this patient group from 60 to 70. They're 10 to 20 years out from menopause. They've never been on hormones. Nobody ever talked to them about hormones because we just didn't do that for the last 20 years. And it was all because of a study that showed that there was an increased risk of invasive breast cancer with estrogen, but it didn't actually show that. Super frustrating. So that was a really long-winded answer. So the short answer is estrogen slows down bone loss, testosterone increases bone growth and slows down bone loss, and progesterone increases bone growth.
I think that was a wonderful answer. I think it's important that the history and the clarification. There are many people that are listening that are right in that window that you're talking about.
Yeah. And I see it all the time because now it's frustrating because now, and actually this is very personal. So my mom actually just texted me literally this morning, her DEXA, and her T-score and her hip was like negative 2.8. It was a big drop from her previous DEXA 2 years ago. And she's 75, right? And so she's 25 years out from menopause, and I know one of her questions when I talk to her later tonight, it's gonna be like, should I be on hormones? And that risk-benefit equation at 75 usually doesn't pan out because the risk of starting it after 25 years of not being on it is your increased risk of having a cardiovascular event or a stroke is higher. Now, it doesn't mean that you can't do it, but you have to have a squeaky clean cardiovascular analysis, and most people it's not.
No. Heart health is the next thing that I'm going to ask, but I just want to say I am so sorry about to hear that your mom is going through that and experiencing that.
Yeah. Well, I mean, how fortunate for her, right? If only she knew an expert in bone health.
Yes, she can get good help. And she's not freaking out.
Totally not freaking out. No.
She knows where to go to get the right help.
Yeah.
Which is a huge thing. The next thing that I wanted to ask is about heart health. calcium, and then looking at medications for bone health and the implications for heart health both.
Yeah. Yeah. So I did a video on this a little bit ago that went live, I think recently. And this one actually really surprised me. So I had heard this thing about calcium causing an increased risk of heart attack. And I thought, oh, that's just stupid. Why would calcium cause an increased risk of heart attack? And I get these messages, I was taking calcium and then I saw that I had an increased calcium in my coronary arteries. And I'm thinking, well, yeah, but like, that's not necessarily related, because we know that people that don't take calcium get calcified arteries too. Like it's not a direct relation. But I finally did a video on it because I had enough requests to, and lo and behold, man, that research is there. So calcium, when taken alone, in not so well absorbed forms, I'll talk about that. But calcium, when taken alone, does increase the risk of heart attack and stroke, just like without question, actually. So that was surprising. Now, if you look at the literature and to pull up the Women's Health Initiative again, it really was a well-designed study. And so I got to give it credit, because there were several arms of the study, and one of them was in taking calcium and vitamin D. Now, they did not give them a lot of calcium or a lot of vitamin D, to be fair. But again, this was a big study with good, very rigorous follow-up, and calcium and vitamin D together did not increase the risk of heart attack. And they were looking hard, believe me. So I'm relatively confident in saying that if you provide calcium in the right amounts, in the right forms, with the right other things, you're not increasing your risk. So we definitely do recommend calcium, but with a lot of caveat. So I mentioned earlier the correct forms. So the forms that were studied in the studies that I mentioned that showed increased risk were calcium carbonate, right, and calcium citrate, which is okay, right?
Talk to me about the citrate. This is interesting.
Yeah, so citrate was in there too, and I think this just goes to show. So citrate's relatively well absorbed, but I think that if you take big doses, and some of these studies use big doses, and I forget the number. It's been a while since I looked at it, but you're talking like 1,200 milligrams of supplemental calcium, right? Or I think some were even more. Gosh, I want to say one. Oh my gosh, I'm thinking of it off the top of my head. I want to say it was like 1,000 or maybe even 2,000 milligrams. I don't remember, but it was a lot. And I think if you give a ton of calcium and your body doesn't know what to do with it, it could potentially do something bad. And this is when people talk to me about the risk of hormones and the risk of peptides and the risk of drugs, people don't usually ask me about the risk of supplements, right? And it's funny, like if you look at those studies, the risk of having a heart attack on calcium was way more than the risk of developing breast cancer from progestin. But yet, people are so scared of estrogen, and people are taking thousands of milligrams of calcium. Anyway, so I think that choosing the right form is important. And I think calcium citrate is an okay form. I think that it has to be paired appropriately. So our approach is this. So we have patients track their nutrition. So we use an app called Chronometer or Chronometer, and we have them track as accurately as they can for at least a couple of weeks. Our coaches will look at that data and then determine, okay, you're consuming so much through your diet. So then let's fill in the gap between whatever you're consuming in 1,200 milligrams with supplemental calcium. I like to use 250 milligrams or less. So I don't like to use big doses, but that means you got to get it in your diet, which then leads to the conversation of dairy and other stuff. But if you can use less, that's better. And then we make sure that you're getting adequate vitamin D. Now, if you go back to the Women's Health Initiative, I think they were giving them like 200 IU of vitamin D, which is that's like a whiff. It's like you looked at it and didn't actually swallow it. So we'll just say very little. We're testing. We're starting people usually on around 5,000 IU of vitamin D, and I have patients that are on up to 20,000 a day. And the reason why we can do that is because we're testing. We know that there's a tremendous amount of genetic variation on how much vitamin D you can absorb, how much you can utilize. So for us to get patients to that goal 80, I think it's nanograms per ml, I want people around 80 to 100. For us to get them there, some people need big doses. I take 10,000 IU a day, and that keeps me around 100. So giving it with enough vitamin D to actually be functional. And then also with vitamin K, and we can talk about that. And then I think if you do all three of those together, it's probably not going to be harmful for you. I can't guarantee that because it's never been studied. But my guess is that your body knows what to do with it.
That's really interesting to think about. So clarification, calcium carbonate, not well absorbed, and then
Not
calcium.
well absorbed. And you'll know the video if you go to YouTube and look at it, because the thumbnail is me holding a box of chalk, because that's what calcium carbonate is.
Yes. And then it matters the amount. So looking at, I think it's interesting to look at below 250 or below.
Yeah. I mean, and we have patients that, if people don't tolerate dairy, and they're not getting it through vegetable sources, then they're not getting a lot of calcium. And so we do have patients that need upwards, 600, 800 milligrams. So we have some different options, and we have, our list of supplements is like a couple hundred long, different options. And so we have a lower calcium supplement that has a lot of the other nutrients for bones in it. And then we have one that's just MCHC, and I'll explain that in a second, in like 200 milligram tablets, right? So we can just titrate it up, and so some people will need 3 of those plus the other one in order to get the calcium that they need.
There's a follow-up question. Once you're at 100 for vitamin D, do you still keep taking it every day? And at what dose? And then what other supplements do you add?
Yeah. So I don't know anybody that has a normal vitamin D. Again, normal for me is 80 to 100. Actually, I should call that optimal. Optimal vitamin D without supplementation. So whether or not you should keep taking whatever it is you're taking at 100, it depends on how long it took you to get there and if you've stayed there. So for me, I know that if I take 5,000 a day and a good quality supplement, I'll be around 100. So for me, I have to keep taking it. If I stop taking it, it drops down. It doesn't work if you don't take it. So yeah, you have to keep taking it. As far as what else to take, it's extremely variable. So that's why I said I have a list of a couple hundred. And then when we go through a patient's report, then we're selecting, and we try not to overwhelm people, like I said before. So like, what are our top 3, our top 5, our top 10? How aggressive do we want to be? But that's out of a list of a couple hundred. I can say in the book, I have kind of like the heavy hitters, the things that you absolutely have to have. And so that would be, I'll just like go down the list. So it's vitamin D, that's calcium. It's vitamin K2 is MK7. It's vitamins A and E, and you can get those last 4 all in one. Omega-3s, I think, are almost globally deficient. It's something that we need to supplement. Magnesium is pretty much globally deficient and something that needs to be supplemented. I think if you start there, that's a really good starting point.
I think that's really an interesting way to look at it. I appreciate you're taking the time to explain how individual that is. There's not just one way to answer this. We're getting pretty close to time, and I appreciate so much you're coming to speak to us today. I'm wondering if you would be willing to share how people can get in touch with you, how they can work with you.
Yeah, absolutely. So
I think it's a huge thing to have a physician who's focusing on this area.
Yeah, well, I really appreciate that. And it's been fun to grow. I mean, I really like working with this patient population. It just speaks to my training in orthopedics, and I just take all of that information and continue to add it and layer it on. So I love working with this group. As far as how to get a hold of us, if you go to our website, you can get directly to us and you can schedule with our team. That's the easiest way to get started. So just go to our website, and that we have 2, like I said, but optimalbonehealth.com is going to be the bone health specific stuff. If you want to just learn more kind of about what we do, go to our YouTube channel and look up Dr. Doug Lucas on YouTube. You'll see all of the playlist on bone health, and in every one of those videos, there's a link to a masterclass. The masterclass is an hour long, just basically me talking about how to treat osteoporosis, both yourself at home, and then a little bit about how we do it. That's your opportunity to one-on-one ask me questions. So go to YouTube, sign up for the masterclass, or if you just want to want to get started, then just go to our website and talk to our team.
That sounds wonderful. Thank you so much.
You're welcome. Thank you.